thyroid and the parathyroid glands. So first we're going to cover the basics, so how things are supposed to work, including anatomy, histology, physiology, feedback loops, and the actions of the thyroid hormones and parathyroid hormones and related hormones. So firstly, let's talk about thyroid anatomy. So the thyroid is located at the C5 to T1 levels normally. There are two lobes, the left and the right lobe, and they're connected in the middle by what's called the isthmus. And this gives it a butterfly-like shape. The other thing important to note is that it's bound by what we call pretracheal fascia. And so the thyroid is anterior to the trachea and the larynx, and it's deep to the sternothyroid and sternohyoid muscle. It is very highly vascularized, so it's supplied by the superior and inferior thyroid artery and drains to the superior middle and inferior thyroid veins. It's also very close to the left recurrent laryngeal nerve. And you might remember this from your cardio lectures last year, but damage to this nerve can cause hoarseness. The other concern is, especially in operations as a complication, is because it is highly vascularized, it has that really ample blood supply, then bleeding can cause compression of the trachea here and suffocation. So they're the two important things to note that might come up in clinical cases. So the left recurrent laryngeal nerves and bleeding because of how highly vascularized the thyroid is. Let's talk about thyroid gland histology. So we have these follicles here, and these follicles are comprised of colloid and follicular cells. Colloid is this central storage area here where thyroglobulin is stored, and the follicular cells around it are simple corpoidal, and this is where T3 and T4 is secreted. Now around these follicles, we also have these parafollicular cells, which are called C cells, and produce calcitonin. A way to remember this is para means next to, or C stands for calcitonin. Calcitonin, which we'll talk about later, lowers the calcium levels in the blood. So next, let's talk about the synthesis of thyroid hormones. First, we have iodide in green here, which crosses from the capillary and into the thyroid follicle cells. It oxidizes into the active form, iodine. Now at the same time, up here, in these follicular epithelial cells, thyroglobulin is synthesized and secreted into the lumen, the colloid here. And so thyroglobulin provides tyrosine. In the colloid, tyrosine and iodine join together to form DIT T2 or MIT T1, and then these iodinated tyrosines join together to form T3 and T4. The T4 and T3 are endocytosed, combined with a lysosome here, and then diffused from the follicle cell into the bloodstream, where it will be taken to peripheral tissue as needed. Okay, now that we've talked about the synthesis of thyroid hormones, let's talk about T3, T4, and iodine. So T4 and T3 float around the body, but T4 is actually a prohormone. So even though 90% of the hormones are T4, it needs to be activated by these deiodinases, so this enzyme, into T3, and then it can actually work as the hormone as it's meant to. So T3 is more potent, but T4 has a longer half-life. So T4 lasts, say, 6 to 7 days, whereas T3 hangs around for 1 to 2 days. And this is important, especially when it comes to the treatment of different conditions such as hypothyroidism, because you will give T4 because it has a longer half-life, even though T3 is more potent. So iodine. Next, almost all iodine is stored within follicles of the thyroid, and it's stored there for several weeks, so you have a good supply's worth before you run out. And this is why some medications, again, we'll talk about this later, will take 1 to 2 months to work because there is already this storage of iodine in your thyroid. Final point is reverse T3, and it is what the name suggests. It comes from T4 and it's an inactive form of T3. Not super high yield, but just so that you know what it is when you see it. Okay, the hypothalamic pituitary thyroid axis. So let's look at feedback loops in relation to thyroid hormones. So we start from the hypothalamus. The hypothalamus, when triggered, releases TRH, so thyroid releasing hormone, which acts upon the anterior pituitary. This then releases thyroid stimulating hormone, TSH, which triggers the release of thyroid hormones from the thyroid, T3 and T4. Now, different factors have different effects on this feedback loop. Thyroid hormones have a negative feedback loop, so when serum thyroid hormones levels rise, this will inhibit hormone release from the anterior pituitary and the hypothalamus. Other factors that affect the hypothalamus, so TRH is increased by things like cold, the circadian rhythm, estrogen, acute psychosis, and of course, as we talked about, the feedback loop, decreased T3 or T4 levels. On the other hand, TRH is inhibited by factors such as severe stress, decreased energy levels, starvation, as well as somatostatin, growth hormone, cortisol, corticosteroids, dopamine, and as negative feedback works, increase T3 and T4 levels. Another thing to note is the difference between males and females. In females, the thyroid gland is larger, and this enlarges even further during puberty, pregnancy, lactation, and the luteal phase of the menstrual cycle because of the changes in estrogen levels. Okay, now let's run through what the thyroid hormones actually do. So overall, the thyroid helps with regulation of homeostasis, regulating the metabolic rate, temperature, and it enters the cells through transmembrane transporters and binds to nuclear receptors. And so things that it does. In the heart, it increases cardiac output, so it increases the force of contraction and speeds up heart rate. It also upregulates, so it increases the number of beta adrenoreceptors. It also acts to increase metabolism. So it increases gut motility, has catabolic effects, so it stimulates breakdown. Think catabolic as catastrophe. Anyway, it stimulates the breakdown of fat. In the muscle, it increases protein breakdown, it increases gut motility, carbohydrate absorption, so it helps with digestion, and it also increases overall your basal metabolic rate. So that increases your oxygen consumption and you'll produce more heat if your basal metabolic rate is increased. Another thing that thyroid hormone also does is that it promotes development. So it's important for brain development, bone growth, skeletal development. So it does a lot of different things. And as you can see, it is quite important and has a lot of different effects on the body. I would remember it in sort of these 3 different categories just to make it easier, that it acts on the heart, acts on metabolism and promotes development, and it increases all these. And hopefully. Okay, and this is a nice summary. You guys can go through this in your own time of the different effects of thyroid hormones in the body. Okay, next, parathyroid gland. So the parathyroid gland is posterior to the thyroid. It's behind it, and its function is to regulate calcium. Most people have 4 parathyroid glands, which are 2 pairs, and the superior ones come from the 4th pharyngeal pouch, and the inferior ones come from the 3rd pharyngeal pouch. and you'll learn more about this in head and neck embryology towards the end of Sem 2, but I'll just mention it now so that when you hear about it later, it might click. Blood supply, you can go through that in your own time. Surgical, so it's important to know that, as you can see, the parathyroid glands are very close to the thyroid, so it may be affected inadvertently in the surgery of a thyroid. So if you inadvertently, while doing a thyroidectomy, also perform a parathyroidectomy, then that will have consequences such as reduced parathyroid hormone and reduced calcium. So the histology of the parathyroid isn't as high yield as thyroid, but for reference, the main cells you need to know are chief cells, which are these small round nuclei, and inside they contain granules of parathyroid hormone. Oxophil cells are bigger, but their function is still not quite clear. Again, this was for completeness sake, not as high yield as thyroid histology, so do know your thyroid histology. Okay, hormones. Let's start with vitamin D. So vitamin D needs to be hydrolyzed to become active, and this happens first in the liver, with the first hydroxyl OH group added. Then in the kidneys, another enzyme adds a second hydroxyl group, which gives us 1,25 dihydroxycholecalciferol, or calcitrol, which is the active form of vitamin D. So vitamin D will act with parathyroid hormone, which I'll talk about soon, to increase plasma calcium concentration, such as in the kidneys, increase calcium and phosphate resorption, increasing dietary calcium absorption in the gut, and promotion of parathyroid action in the bones. Now, the parathyroid hormone is a protein. Low levels of calcium will stimulate increased parathyroid hormone secretions, and high levels will feed back negatively. Parathyroid hormones act to increase calcium levels in the blood, but decrease phosphate levels. In the kidneys, calcium is reabsorbed and phosphate is excreted. In the gut, like vitamin D, more dietary calcium is absorbed. In the bones, resorption is increased. It will also increase the levels of active vitamin D in the blood to help bring calcium levels up when they're low. So this here is a nice summary of the negative feedback, which is just what I've spoken about in an easier to understand diagram. So if you can wrap your head around this, it will be a very good holistic picture putting together the different actions of parathyroid hormones on the kidneys and the bones and how it relates to calcium and vitamin D. So here we have parathyroid hormone secreted, and that obviously increases the plasma levels of parathyroid hormone. In the kidneys, what PTH does is increase calcium and increase vitamin D. And how does it increase calcium resorption? So you have less excretion. And in the intestines, because of vitamin D, you have increased absorption. And what that does overall is increases calcium. On the other hand, in the bone here, you have increased resorption. So the bones, the calcium is being released into the blood. So where does that put us? So we have less excretion in urine, more absorption in the gut, and more release of calcium in the bones. And overall, that acts to restore, to increase plasma concentrations back up towards normal. Okay, so calcium. Calcium is important for many things in the body. It's important for things like maintaining membrane polarity, for muscles, if you remember the excitation, contraction pathways, coupling, enzymes, coagulation of blood, things like bone, teeth, structure, or calcium is very important. And bone is the largest reservoir. If you think about it, that makes sense. It's where a lot of calcium is. So that is why when parathyroid hormone acts, one of its actions is to increase resorption of calcium from the bone. It's also excreted in urine and feces. So even though we eat or we get a lot of calcium in our diet, a large amount is just excreted. And the total body calcium is balanced by hormones. I also want to take a moment to mention calcitonin. This is a thyroid hormone, which we mentioned a while back, but it is secreted from the parafollicular cells, or the C cells. Remember C for calcitonin. And this acts to decrease serum calcium and phosphate. So it's essentially the opposite of parathyroid hormones. When blood calcium level rises, then the thyroid gland will release calcitonin to bring it back down, right? So if calcium is high, we release calcitonin to bring calcium down. When calcium is low, we release parathyroid hormone. So essentially, they're the two opposite hormones. Okay, let's also quickly talk about the bones. This is handy to help us understand osteoporosis later. So first on this side, we have osteoclasts. These resorb bones to release calcium and phosphate into the bloodstream. I usually remember C as catastrophe, hence the bone is being broken down. On the other hand, we have osteoblasts, which take calcium and phosphate from the blood to build bone. And I remember B as builders. So a number of hormones affect bone resorption and formation. The ones important to note are on the right. So these ones here. Parathyroid hormones increase bone resorption. Cortisol blocks calcium absorption and interferes with osteoblast formations. And changes in thyroid hormones will also increase bone breakdown, leading to more brittle bones. On the other hand, hormones like growth hormones, insulin-like growth factors, and even sex hormones like estrogen and testosterone will do the opposite, favoring bone formation and making your bones stronger. The last thing to discuss are rank ligand and OPG. So rank ligand is expressed by osteoblast cells. They bind to rank on osteoclasts and increase bone resorption. How I think of it is the builders are sending a form or a letter, so the builders are sending a form or letter called rank ligand to the demolisher's mailbox. And that inbox is rank, which gives them the okay to demolish more. So, okay. And then we have OPG. OPG is a protein produced by osteoblasts. Now, OPG inhibits rank ligand from binding to receptors. This decreases the rate of bone resorption or breakdown. If we go back to my previous analogy, imagine OPG as a project manager who stops the letters from reaching the demolishers or osteoblasts. Estrogen stimulates OPG, so the more estrogen, the less bone breakdown, because less rank ligand from osteoblasts is binding to rank on osteoclasts. This is why postmenopausal women with less estrogen have an increase in bone resorption, which is why they're more likely to have conditions like osteoporosis. Okay, now that we've talked about the normal physiology of the thyroid and parathyroid, let's talk about what happens when things don't work as they should.
Okay, so the first thing I want to talk about is thyroid function tests and looking at the difference between primary and secondary hypothyroidism. So, let's think about the thyroid hormones that are important. We have TSH, T4, and T3. Now, in hypothyroidism, then we have a decreased amount of T3 and T4. And so what does a decreased T3 and T4 lead to? It leads to inhibitory feedback, which goes back to the anterior pituitary and tells the anterior pituitary to increase TSH hormones. Now, in primary hypothyroidism, the issue is with the thyroid. So the thyroid doesn't respond to the increased TSH. On the other hand, if the issue was secondary and not related to thyroid, then TSH would also be decreased because the anterior pituitary isn't sending the signals that the thyroid needs to respond to. And the same thing is true if we look at hyperthyroidism. So in hyperthyroidism, we have too many circulating thyroid hormones. And if it was a primary issue, it'd be an issue within the thyroid itself, where it's not responding to TSH telling it to slow down. If it was an issue with the anterior pituitary would be telling the thyroid hormones to be overactive. It would be sending too much TSH and hence causing the thyroid to work overtime. There's also subclinical hypothyroidism, which essentially is where TSH here is decreased, but it hasn't yet affected T3 or T4.
So this is a really nice table Malika put together, which you can read over carefully for revision. We've talked about primary versus secondary thyroid pathologies, so do understand that. When we talk about the clinical features of hyperthyroidism and hypothyroidism, they're essentially the opposite of each other. Hyperthyroidism, your thyroid is overactive. Think back to the function of thyroid. Increased thyroid hormone raises your heart rate, digestion, your basal metabolism. So we see heat intolerance, tachycardia, diarrhea, unintentional weight loss. I remember it as mostly everything being increased. Hypothyroidism is the opposite, everything being slower and decreased. Think slower heart rate, slower digestion, depression, decreased reflexes, and heavier periods. In hypothyroidism, patients will often have gained weight. Another clue in an exam is carpal tunnel syndrome, on top of more non-specific syndromes such as fatigue and weight loss. When suspecting thyroid pathology, the first line investigation is a physical exam history. Then you want baseline bloods, looking for other causes, as well as thyroid hormone levels and maybe an antibody screen. An ultrasound is also a cheap, non-invasive test to look for thyroid enlargement, nodules, cysts. Of hyperthyroidism. Thyrotoxicosis is what we call the syndrome of hyperthyroidism. It can be caused by thyroid disease such as Graves', some thyroiditis, from toxic goiters or thyroid cancers, or from non-thyroid causes such as drugs or tumours from other sites. We'll run through some of the main ones. First, Graves' disease. This is an autoimmune condition where the body is attacking itself, usually occurring in young women. In this case, thyroid-stimulating antibodies are produced and these activate TSH receptors on follicular cells, increasing synthesis and secretion of thyroid hormone. The overactivity causes hyperplasia of the thyroid gland, so a goiter. On top of hyperthyroidism signs and symptoms, Graves' disease also causes other signs. Importantly, remember eye changes, including exophthalmos, thyroid stare, lid retraction, and lid lag, as shown in this picture here. Non-pitting pretubular myxedema due to increased hyaluronic acid in the dermis. Other causes of hyperthyroidism include toxic nodules, so nodules that behave abnormally, become enlarged, produce excess thyroid hormones, and do not respond to negative feedback. Subacute thyroiditis also comes up on exam. This is inflammation, the itis, of the thyroid, usually occurring after viral infection of the upper respiratory tract. What happens is there's initially an increase in the release of thyroid hormones, so hyperthyroidism first, which declines into hypothyroidism. Some people may have permanent hypothyroidism after, but most will eventually recur normal thyroid function. Hypothyroidism. Hypothyroidism also has many causes. It can be congenital if the thyroid gland doesn't form properly, autoimmune such as in Hashimoto's, because of iron deficiency, because of drugs, or even iatrogenic, such as because of surgery. Keep in mind also secondary causes, so causes not directly because of the thyroid, such as if the pituitary is underactive and fails to produce TSH. Again, let's run through the main ones. Somewhat opposite to Graves' disease is Hashimoto's disease. In Hashimoto, autoimmune antibodies juice destroy the TSH receptors and damage the thyroid's ability to function. This also produces a goiter as the thyroid initially works overtime to try to compensate. Iodine deficiency. In places where iodine deficiency is endemic, this is more common, such as if there's not enough iodine in the soil. These days, we can get iodine from dairy, seafood, eggs, and even fortified foods such as iodized salt. Now, hypothyroidism in the mother can cause congenital cretinism, stunting a baby's physical and mental development, but it's much less common now because of screening and supplementation. Finally, iatrogenic causes. Some drugs, especially amiodarone, can cause hypothyroidism, and surgery or treatments such as with radioactive iodine or a thyroidectomy will also cause hypothyroidism. I really like to visualize pharmacology by its mechanism of action, so let's work through this diagram. Thiamides. So these drugs are used in hyperthyroidism, and what they do is bind to tyrosine and interfere with the organification of iodine, and also inhibit peroxidase, so it cannot join with tyrosine to form thyroglobulin. Because the thyroid stores iodine, it can take 4 to 6 weeks for the clinical effects to become apparent, and it can also cause congenital hypothyroidism. Iodine over here. Now, in the short term, when given, it can actually act as an inhibitor in high doses. More effective than that is radioactive iodine, which has localized cytotoxic effects. However, this does have a 1 to 2 months delay because, as we talked about before, the thyroid does store iodine. On the flip side over here, we have levothyroxine, and this mimics T4. And why do we give T4? We give this instead of T3 because T4, if you remember back to our physiology, T4 has a longer half-life than T3, so stick around longer and be more active that way. And another lovely table from Malika for a more detailed look at the drugs. I would say all the information here is probably the most high yield of everything you need to know in each of the sections: mechanism of action, use, side effects, contraindications. So have a read through. A lot of it will become straightforward once you understand how it works, but also some things you're just going to have to memorize, such as side effects. So goiter is an enlargement of the thyroid gland, and there are varying causes. It can be hyperthyroidism or hypothyroidism, since the thyroid has to compensate. It can also be a completely different reason, so such as cancer, and that would cause, say, an actual lump to form, and so that could also present as a goiter. There are different sort of buzzwords that you can have a look at, which may help you kind of eliminate, especially in EMQs, eliminate different options. Okay, now we want to talk about parathyroid hormones, which can also be increased or decreased. Hyperparathyroidism has increased excess PTH and increased calcium, and it can be caused by particularly chronic kidney disease. And clinically, there aren't a lot of specific signs or symptoms, but bone pain, fractures, and lethargy are often present. Now, hypothyroidism is when you don't have enough parathyroid hormone, and this can be after an operation, such as after a thyroid surgery where you accidentally damage the parathyroid glands, or it can be autoimmune. Some key tests: Shostak, where there's an abnormal spasm of the facial muscles when you tap over the facial nerve near the lower jaw, and Trousseau sign, which occurs when you take blood pressure. Now, hypercalcemia or high calcium is commonly caused by high PTH levels. And so what does calcium? And Now, in hypercalcemia, you have increased bone resorption, so bone pain, osteopenia, osteoporosis. There is increased calcium resorption from the gut, which may cause nausea and constipation. There is decreased renal calcium excretion, so this may cause kidney stone. It may also cause psychiatric issues like depression, as well as lethargy and confusion. And bones, stones, moans, groans, psychiatric overtones is really good mnemonic to remember. So just think of all these signs that a patient could present with, and that it may point to electrolyte imbalance, especially calcium. So osteoporosis. With the bones are porous, they become brittle and weak and prone to fractures because of the low bone strength, which is a progression from osteopenia. So you have reduced bone mass and deterioration. So let's look at the risk factors. So estrogen. Now, estrogen inhibits bone resorption. So after menopause with less estrogen, the risk factor is increased. Corticosteroids reduce the body's ability to absorb calcium and increases bone resorption. So risk factors are important, and you want to think about that. Increased age, previous fractures, family medical history, as with lots of things, smoking, alcohol use also increases your risk factor for osteoporosis. Osteoporosis itself is asymptomatic and is usually diagnosed only after a fall and fracture. DEXA scores are the investigation used, and a standard deviation of less than -2.5 is defined as osteoporosis. So to prevent osteoporosis, the first line is usually at lifestyle factors, modifying risk factors, things like smoking cessation, alcohol reduction, increasing calcium in the diet if you can, increasing exercise, changing medications such as corticosteroids if you can. Supplementing calcium and vitamin D may also be useful. A nicer table of the same thing that I've just went through. And we'll wrap up with another summary table looking at drugs. First up, hormone replacement therapy, where you give estrogen. Now, this is a short-term solution, mainly because there is also an associated increased risk of breast cancer and cardiovascular risk. Selective estrogen receptor modulators are better because it takes away that breast cancer risk while maintaining the benefits of estrogen. However, there is still a little bit of the cardiovascular risk associated. Bisphosphonates inhibit the formation and activity of osteoclasts. In the oral form, the patient needs to swallow it whole and remain upright for 30 minutes to an hour after to prevent esophagitis. You can also give it through IV with zoledronic acid injections. A particular side effect to remember here is osteonecrosis of the jaw. Denosumab is a monoclonal antibody, as you can tell by the mab ending, and it works against RANKL. It reduces the number and function of osteoclasts and is given via a biannual injection. The last one to talk about is teriparatide, which stimulates bone formation, as opposed to the other drugs, which inhibit bone resorption. So it stimulates osteoblast development and activity. However, as of currently, the treatment is restricted to a total of 18 months. So that's a lifetime restriction. Any questions you have, do feel free to post it on our Curious Cat or message any one of us individually.